The ability to improve palliative care within cancer has a long history. The Temel Study demonstrated that in a group of stage 4 lung cancer patients, if they received concurrent palliative care, they were less depressed. They had clearly written advance directives about what kind of care they wanted. They chose hospice care sooner, and their quality of life was better. So much around the palliative care has been that it's about death, it's about dying, it's about giving up. And I think what this study demonstrated that this concurrent use of these approaches could improve people's quality of life, extend their life in certain situations, and clearly played a role in their managing their depression.
I interpret the study to mean not that every patient with lung cancer or every patient with cancer needs to be seen by a palliative care specialist. I interpret that to mean that every patient who would like to be seen by a palliative care specialist, by somebody who will concentrate more on their symptoms, more on their decision-making, and facing the future in that particular way, every patient who would like to talk to a palliative care specialist should have the opportunity to do so.
Palliative care, morphine access, pain control, supportive care, all the measures of support for the patient must be fully integrated at the healthcare system level.
When you have a therapeutic option for treating an advanced cancer, you need to have a palliative program integrated into it right in the beginning so that the patient's symptoms are taken care of.
What's happening at the moment is that 30 to 35% of our health budget is spent in the last 90 days of life. That's inappropriate, and it's being spent on things that don't help the patient. We don't do much research in palliative care. It's our responsibility as an extended community to study this and also to move it into action.
I fully agree that this is a very important part, and it is highly underestimated, unfortunately. It is much more interesting for many researchers and also very often for the press to have a new agent, but best supportive care and palliation is not that interesting.
I am of the firm belief that if we educate the medical profession, because it is for them to suggest to the patients. Otherwise, no palliative care physician can convince an oncologist.
To integrate palliative care, I think palliative care has to be introduced as a curriculum at the undergraduate level and as a postgraduate level, and a training program should be done. That if you are going in for a certification for oncology, in medical oncology, you need to spend about 3 months' time in a palliative care or 6 months' time in a palliative care unit, doing it upfront and right.
The reality is we don't have enough oncologists. The reality is that we need to be able to understand that there are palliative care specialists who in the past may be trained as oncologists but are doing primary palliative care. And that this specialty of palliative care, which is now a board specialty in the US and in many countries around the world, is an approach to be able to combine the best cancer care with the best symptom management and psychological support for patients.
I think a multidisciplinary approach involving specialists in supportive care, not only physicians, but also nurses that are very well trained and very well informed, is key to improve patient care in that way.
It should be integrated as a fact in the basic nursing training, that it's not just quick treatment and there goes your patient, that it's a continuing process, that nurses have to be involved because we're trying to save hospitalization costs, time, and giving the patient quality of life.
Well, I think to start with, a person that has a diagnosis of cancer needs to be holistically treated.
Well, I think that palliative care is really crucial for the management of patients with cancer. And I think that these patients should be followed from the beginning, both from a medical oncologist and from a palliative care specialist.
We should be sensitive to each individual patient's needs. The patient who does not want to talk to anybody and just take their medicine, well, for that individual patient, that might be the best thing to do. The patient who needs to talk to a counselor immediately because they are overwhelmed by the whole problem will probably do better to talk to a counselor immediately, and we just need to be sensitive to that.
Palliative care begins at the time of diagnosis. And if somebody asks, are you going to dump everybody into the incurable basket? We say no. Palliative care is like a menu card in a restaurant. You have what we call as the starters, the initial, which is good communication. Giving him information at the rate at which he wants it. Helping him to take an informed decision. Understanding what are the other things that go on, the reactions that are there, because after all, he's a human being with a family.
Palliative care integrated into the oncology setting is good for patients. I wouldn't say that it extends life, but it reduces hospitalization, and without doubt, it increases quality of life of families, not only for patients, but for families too.
Is it not cheaper and much more effective to integrate palliative care in the treatment instead of spending millions for drugs that prolong life of 1 month? I think we should do both. We should give new treatments and do research on new drugs, and we should integrate certainly palliative care more in the treatment of patients.
I always look at palliative care as a parallel important venue that had to be integrated in the direct anti-tumor treatment you are applying to the patient. And I think that has been also one of my goals over the years, and I know that the patients have appreciated that.
At the Shari Tzedek Medical Center in Jerusalem, we have embedded palliative care as part of the oncology service from the inception of the department 18 years ago. Every patient with either advanced disease or with inadequately controlled physical or psychological symptoms at any stage of their disease will be referred for a palliative care evaluation to develop a co-joint plan of anti-tumor therapy as well as palliative therapies to get them through to try to get the best possible outcomes for them.
It is part of the management of a patient with cancer in any stage, and if he needs more palliative support, then it should be given. It's clear that the oncologists by themselves have no time to do this. The system should do this, and in different countries probably the systems for palliative care not very much and very good elaborated, including Germany. So there's much to do.
I think that there's absolutely no doubt that everybody should have appropriate palliative care concerning pain control, concerning psychological well-being, concerning all aspects, and there's no doubt, not the least doubt, that this is part of oncology care which should be appropriately done.
It's a continuum. We should not be saying that one is right and one is wrong. It just depends on what the patient is, what is the situation, then we use different words. But what we have to do is that we have to care for the patient.
100% of people do die in the world. We have to, in our journey with cancer, in our experience with other non-communicable diseases, recognize that in actual fact death is inevitable and develop a way that we actually approach this in a healthy manner. That's a big challenge. That's somewhat controversial in the face of the current oncology practice that we will find a cure. But in actual fact, the reality is we're all going to die, and palliative care should be part of all our lives.